Okay, perfect. So, good morning, everyone. Thank you for joining us for Monty Heart this morning. We're very fortunate to have Dr. Wissam Jaber to present us this morning on the evolution in the interventional treatment of pulmonary embolism. Dr. Jaber is the program director of interventional cardiology fellowship at Emory University School of Medicine. He's also the director of the cath lab at Emory University Hospital. He's a leader in the field of the treatment of pulmonary embolism. He was the first author of the recent peerless trial. So I'm sure we'll hear about this. So I think this morning we're in good hands to learn more about this interesting topic. And I think it's all you now.
Thank you very much. Very nice to see you. Very nice to be here and appreciate the invitation. And just a word about Louis was one of the best fellows that actually I worked with. He did CTO fellowship with us, and I was always most comfortable working with you to for the case to go very well. So thanks to I'm glad to see you again and happy to give this talk. You also feel free to interrupt me if you have questions in the middle. I'll start with a quick case here just to illustrate the point. This is a case that I did maybe 6 or 7 years ago. She's 17-year-old, came in with shortness of breath, collapse, CPR by EMS, and then in the ER. But then she stabilized to get a CTA, and you can clearly see on CTA a central clot here obstructing the main PA saddle. You see the RV being very big. And at that time, she was in a different hospital, but even at our hospital, she would have received also 100 milligrams of TPA, which is the appropriate treatment based on the guidelines, and she had an immediate improvement. Now, this was a while back. These days, such a patient we probably treat like a STEMI. If she's stable enough to go to the cath lab, we take her to the cath lab in our practice and do thrombectomy on her. If she's way too sick, she may get TPA or she may get placed on ECMO from the get-go. We're using less and less of the TPA. But for the sake of this case here, she got that TPA. She improved, but she was still hypoxic. The RV was enlarged. And at a PTT scan, you can see that there's still a central clot here in the right main PA. The saddle is gone. The RV is a little better, but this also illustrates the fact that the TPA does not get rid of everything, and you still have an obstructive clot in many cases. And at that time, we took her, we did a flow retriever thrombectomy on her, happy to get clots out, which is typically what we see these days. We're very happy with the clots, but you see this all over Twitter these days, so it's not as exciting anymore. But the point is that this procedure works and we can get the clots out fast. And you can see here the echo before and after. Her PA pressure on the table got much better. She felt better subjectively. You can see the echo before her procedure and the echo next day after the procedure. The RV is much smaller. The LV is happier. This is just to illustrate that PE is an obstructive disease, is a mechanical problem. It's an obstruction to the pulmonary artery where we feel that the solution should be mechanical to try to remove that obstruction. And as we kind of like talk about the evolution of PE treatment, treating PEs over many years have also allowed us to treat many other things. So we became better at thrombectomy in general. And these are cases, for example, of a non-surgical candidate patient with clot here in the right atrium. And some of that clot, if you noticed here, was going through the PFO. And now it's easy for us to just go in and use ice and aspirate the clot using a big aspiration catheter. It's all these are feasible, and we're becoming better and better as a community at treating this disease. Now, just a quick reminder here about the risk stratification of pulmonary embolism and what we use in terms of talk. We used to use massive, submassive, and low risk, and probably many people still use it, but most of the time, and especially in publications, we use the European risk stratification because it is less confusing. High risk is the patient that is hemodynamically unstable, meaning hypotensive or arrest, or kind of this is the patient at extreme. Intermediate risk are patients that are not hemodynamically unstable, meaning they're not hypotensive, but they have evidence of right ventricular dysfunction. And remember that this is a continuum. So it's not that patients are either this or that category. Patients can move between categories, and they could be intermediate low risk, but they could also be intermediate high risk, meaning they have both RV enlargement and increased SPSE score, and increased cardiac enzymes. And the low risk are the patients that have none of these. This is important because it correlates with mortality. So patients at high risk have a mortality up to, in some series, up to 50% based on how high it is. But in general, if you take all the patients together, the PE-related mortality is 15%, and the low risk 0.5%, but the intermediate high risk is still high, about 5%. And this is a higher mortality than what we see with acute myocardial infarction. Now, the guidelines recommend anticoagulation alone for most of the population except high risk, and recommend lytics for the high risk patients. And the guidelines say surgery or catheter therapies when lytics are contraindicated or have failed, but we believe that the guidelines are a little outdated, and in our practice and in many other practices, we believe that the high risk patients are underserved because we're still not giving enough patients lytics. A lot of patients still have significant contraindication to TPA, and there's a 5% risk of intracranial bleed with TPA. Same thing with the intermediate high risk. If we just treat them with anticoagulation, the mortality is still unacceptable. A third have normotensive shock. I'll show you this data. And they may end up with some morbidity down the road. And in my practice, at least, I'd like to get these patients better, faster, and get them out of the hospital. If we look at the FLASH registry, which is the biggest registry in PE of patients taken to the cath lab, these are patients, if you look at the patients that have normal blood pressure, a third of these patients, 34%, had normotensive shock, meaning their cardiac index was less than 2.2. That means that they're really not that stable. And a little kind of change in their situation might tip them over. And there are some factors that predict this. So these are patients that are normotensive, but they have subclinical shock. And these are the patients that we like to be aggressive with. And the more you have of these factors, the more likely the patient is going to be in shock. Elevated troponin, elevated BNP, severe RV dysfunction, saddle PE, concomitant DVT, and tachycardia. And these are the patients where you see improvement in PA pressure when you take them to the cath lab, and you see an improvement in cardiac index. Now, when we say we want to be aggressive with these patients, obviously, the thought initially was TPA or systemic lytics, and this is the latest trial on that with tenecteplase in Europe. The PYTHO trial, which is a highly coded trial, showing that if you give patients TNK, they do improve. You improve their risk of hemodynamic collapse, but death itself doesn't change, and probably owing to the fact that the significant bleeding occurs with TNK. A risk of major bleeding is 11%, and hemorrhagic stroke was 2% in this patient population. So we really now rely more on interventional treatment if we really want to treat patients in the intermediate risk category to try to avoid bleeding from TPA. And when we say interventional treatment, we're talking about two general categories: catheter lytics and mechanical thrombectomy. Now, catheter lytics, you all kind of like know about the ECOS catheter, which is ultrasound assisted infusion of TPA with a catheter. But when we say catheter-lytics in general, we mean any catheter-lytics. It can be this or that. And it's usually a 4 or 5 or 6 French multi-side hole infusion catheter that you put in the clot, and you infuse over anywhere between 6 to 20 hours, something around 1 milligram per hour. So much lower dose of TPA, and easy to do, right? Easy to do in the cath lab. Everybody can just put a catheter in the clot. Now, this was shown in a small trial, Ultima trial, to be better than just using heparin in the RV to LV ratio at baseline to 24 hours and at baseline to 90 days. So better than just giving heparin. And based on that, the ECOS catheter got FDA approval for treatment of acute pulmonary embolism. But there has been more data since then, and there's this knockout PE registry that was recently published, about 500 patients, most of them intermediate high risk, but some high risk that were treated prospectively with the ECOS catheter. And you see here that the major bleeding was only 1.6%, so much less than what you expect with lytics. So definitely better than systemic TPA. Recurrent PE 0.4% and 30-day mortality 1%. So based on this patient population, you expect higher mortality and high recurrent PE. So something is encouraging there. Obviously, this is not randomized data, but this is encouraging real-life data. Now, the advantages of catheter lytics are that they're easy to use and teach, they're fast, short lab time, reasonable safety data based on what I showed you, less than TPA, less TPA used than systemic lytics, so less bleeding. The disadvantages are that we still use lytics, right? Up to 30% of patients have contraindication, including post-surgical patients or post-stroke. We see a lot of these. It also requires ICU stay for hours of infusion, and it takes a few hours to work. It's not an immediate thing. So these are the disadvantages of using catheter lytics. Now, before I talk about thrombectomy, just a word for the Bashir catheter, which is not just catheter lytics. I don't know if you guys use it at your center. We call it pharmacomechanical thrombectomy. So the Bashir catheter, Riaz Bashir is a friend of mine from fellowship at Temple. I mean, he's at Temple now. We did fellowship together at Mayo, and he came up with this idea of catheter lytics, but using a basket of multiple nitinol limbs of that basket. Each of them works as a catheter lytics, and it has side pores that deliver the lytics, and it expands as the clot resolves. So it continues to kind of like reach the clot, and it macerates also the clot. Was shown in the IDE study to be relatively more effective than others. If we just look at the CT scan and the release of and the improvement in the obstruction index on the CT scan seemed to be very promising with this. And actually now we're running a trial. I'm leading that trial on just using this catheter in the cath lab and injecting 4 milligrams of TPA in each lung while macerating the clot and sending the patient back to the floor as opposed to putting him in the ICU. So the treatment in catheter-lytics is also changing to not require ICU stay. Now, to go back to my original kind of dichotomy of catheter-lytics versus thrombectomy. Now, when we talk about thrombectomy, large bore FDA approved are 3 right now. Inari, FlowTriever, the Indigo Penumbra, which is 16 French. The Inari is 20 to 24 French. Indigo is 16 French. The AlphaVac, which is kind of like an evolution from the old AngioVac, that was a 26 French catheter, mostly for central clots. They adopted it in an 18 French catheter with a suction cup for the lungs, pretty malleable, and it goes up to the lungs, use it without a wire. So these are the 3 FDA approved based on IDE trials. And obviously now there's many catheters that you will see on the market that are coming out. An IDE trial has finished on one of them, others are almost done. So there's going to be a lot of these catheters you will see, and it's hard to tell which one is going to beat the other. We'll stay tuned for that. And obviously, like I mentioned earlier, we've been able to remove all kind of clots with these catheters. Some of them are more organized than others, but in general, these are pretty successful. We learned with time that what removes the clot is really aspiration and suction of these clots rather than any other sort of maceration or grabbing the clot. Grabbing doesn't work. It's really just strong aspiration, strong suction. Now, the FlowTriever catheter was shown in the FLASH registry, which is the biggest prospective PE registry on any interventional treatment. 800 patients treated with a FlowTriever thrombectomy in real life. It's been shown to be relatively safe and effective. And again, this is a single-arm registry. This is not a randomized trial. And in this registry, we had mostly intermediate high-risk patients, but also high-risk patients, 8% of the population, big RV to LV ratio. Notice the lytic contraindication is 30%. And despite all that, the mortality at 48 hours and at 30 days was less than 1%. So that's what's encouraging about this. This is not what we expect in this kind of patient population. ICU length of stay was 0 as a median, so which means that most patients did not require ICU stay, and the procedural length was not that long. But most importantly, we almost always see immediate improvement in hemodynamics on the table. So we see heart rate improvement, mean PA pressure drop, and cardiac index increase in the patients with low cardiac index at baseline. Now, thrombectomy catheters, if you want to compare them in general to other catheters, the advantages are you use no lytics, no ICU stay is necessary. You see immediate improvement in hemodynamics and clot removal, which you do not see with catheter lysis. The disadvantages are that you're still using large bore access, so some practices and some docs may not be comfortable with large bore. There's a learning curve to using them. There's blood loss from aspiration. There's also anatomic considerations. If you have both femorals that are occluded, you have IVC clot, you don't want to go through the IVC, you're not going to take these through the neck, so you use catheter lytics. There are some distal clots that you may want to use catheter-lytics versus thrombectomy. So there are some anatomic considerations where you cannot always use these catheters. This is where the disadvantages are. Now, there has been no straight comparison between both, and there has been proponents of either one or the other until we did the peerless trial, which is to date the largest completed randomized trial in PE treatment and PE interventional treatment, which was a randomized trial comparing catheter-directed lytics using any catheter on the market, so not just the ECOS catheter, versus large bore mechanical thrombectomy with a FlowTriever system. Patients had to be intermediate high risk, so RV has to be enlarged with additional risk factors, so increased troponin or syncope or heart rate more than 100, etc. And the patients, 550 patients, were randomized one-to-one to one of the treatments. The primary endpoint was interesting and kind of subject to debate. It's a win ratio in a hierarchical fashion of those factors. So they're put in order of importance. Number one is all-cause mortality. Number two is intracranial hemorrhage. Number three is major bleeding. Number four is clinical deterioration and or bailout. And this was all adjudicated by an independent committee. And finally, ICU admission and length of stay. And the win ratio allows us here to prioritize the factors so that we're not lumping everything together, and also allows to combine a non-dichotomous outcome like ICU length of stay together with a dichotomous outcome, for example, major bleeding or intracranial hemorrhage. Now, as expected, this is not a surprise, that the primary outcome that includes ICU length of stay was significantly positive in favor of mechanical thrombectomy with a big win ratio of 5-1. But if you remove the ICU length of stay, the secondary outcome was 1.3 win ratio that was not statistically significant. But the important finding from the trial is really going into the details of the outcome. All-cause mortality, which was surprisingly super low, so only one patient died in this trial as an inpatient. Intracranial hemorrhage was also low, was not significantly different. But when it comes to deterioration and or bailout, it was significantly different in favor of mechanical thrombectomy. Obviously, the ICU admission was in favor of mechanical thrombectomy, and also ICU stayed beyond 24 hours. So when patients go to the ICU with catheter-lytics, they tend to stay more than 24 hours longer than they do with mechanical thrombectomy. Other important findings in the trial that was not necessarily expected was total hospital length of stay was almost a day shorter in mechanical thrombectomy, and 30-day all-cause readmission was 7.9% in the catheter-lytics versus 3.2% in the mechanical thrombectomy, and was statistically significant. If you look in details at the clinical iteration and therapy escalation, you see that with the catheter-directed lytics, there were some kind of serious events. So these are not very necessarily soft events. So cardiac arrest, high-grade AV block, respiratory failure. But if you look at the mechanical thrombectomy, most of these were softer endpoints, so increased oxygen requirement or hypotension. And the other thing that we found is that most of the outcomes that happened in the mechanical thrombectomy happened during or immediately after the thrombectomy, but resolved at the end of the day, versus the catheter-lytics. Most of these events have to happen after the lytic treatment over the next day or two. And this may be related to something that we also found, that mechanical thrombectomy achieves earlier outcomes in these patients. So whether it comes to dyspnea score or New York Heart Association classification or RV function or respiratory rate, all these things look better at 24 hours in mechanical thrombectomy compared to catheter-lytics. However, despite these early wins, if you look at heart endpoints at 30 days, whether it's all-cause mortality, whether it is major adverse events, even if you look at patients' functional status, New York Heart Association or dyspnea score or quality of life questionnaires, all were similar at 30 days. So in conclusion, peerless demonstrated superiority of mechanical thrombectomy compared to catheter-lytics in the treatment of acute intermediate risk PE, but it was driven mostly by less ICU stay. There was no difference between groups in mortality, ICH, or major bleeding, but which I did not show here, it was a low bleeding risk population. The relative contraindication for lytics in this patient population ended up being 4%, which is not really was intended. And if, like I showed you earlier, about 30% of PE patients we see have some relative contraindication to lysis. So we expected more patients with bleeding. So maybe if we included patients at high risk of bleeding, would have seen some difference between catheter-lytics and mechanical thrombectomy. The way I look at this data is that it was really a general win to all interventional therapy because mortality was very low. The patients did very well long term, better than one you expect with just anticoagulation in this patient population. But still, we saw some wins for the mechanical thrombectomy, mostly in less clinical deterioration or escalation of therapy, faster clinical and hemodynamic improvement at 24 hours, less hospital length of stay, and fewer readmissions through 30 days. Now, there are a lot of criticism for the trial and multiple limitations, and this could be discussed. Obviously, the ICU use as an endpoint was kind of like a major criticism point. I counter that with the fact that we use the win ratio to try to kind of put that last and look transparently at all the other factors. And it's good to look at this important cost metric. I mean, it's really utilization of resources metric in a randomized trial to understand how that fits. And we will be doing some cost analysis down the road on all this. The other limitation is that we use different catheter lytics, not just the ECOS catheter, different catheter lytics that are on the market, but we really and different infusion length. So it was not all the median was about 12 hours, 12 to 15 hours, but it was all variable and was not protocolized. But we did that on purpose because we wanted really to simulate what's out there in practice and not use a very rigid standard for the trial. And the final big criticism is that the trial was not really against standard of care. So if you're looking at mechanical thrombectomy, it's probably a kind of more meaningful trial down the road to change the guidelines would be to evaluate against standard of care, which is anticoagulation. And this is ongoing, and we'll be able to see the outcome of that. So it happens that all these trials were kind of conceived at the same time, but the peerless trial was kind of ended first. But we expect, for example, the HI-PEITHO trial to give us its results at the end of this year. HI-PEITHO trial is the ECOS catheter versus anticoagulation in patients at intermediate high-risk PE with additional risk factors with the hard clinical outcome. So we're hoping to see the results of that soon. And there are other trials that are ongoing. So there's the PE track trial, which is NIH funded trial looking at intermediate risk PE patients randomized to anticoagulation versus any catheter therapy. And the interesting thing about this trial is that the outcome is functional status and cardiopulmonary stress test at 3 months and 12 months. So really the question is, treating these patients aggressively early on, does that help them long-term in terms of functional status and cardiopulmonary function? Peerless 2 trial is an NRA-sponsored trial looking at intermediate high-risk PE patients, anticoagulation versus large bore aspiration, 1,200 patients to be recruited, and it's already ongoing. And the outcome is a clinical outcome, mortality, clinical iteration, and dyspnea score. And the PEITHO 3 trial is done in Europe, although it's not really interventional treatment. It's investigating this idea of giving these type of patients half-dose TPA, 50 milligrams as opposed to 100 milligrams, compared to anticoagulation with a clinical outcome. So it's an exciting time of all these trials ongoing for PE, where in the next couple of years we'll be able to get a lot of data and maybe move the treatment outcome. In the meanwhile, how does my practice look like? So what patients do I select to take to the cath lab and do thrombectomy on? I look at both clinical presentation and imaging. So it's not just one or the other. We cannot rely on just CT showing quote unquote a massive PE. So I want to see how the patient looks like. The patient has to look sick. For example, syncope is one factor I don't like. They have to have either hypotension or maybe some tachycardia, hypoxemic, or severe RV strain, increased biomarkers, increased lactate level. The more you have of these factors, the more likely the patient will benefit from your intervention. Now, sometimes I take patients with lesser clots, with lesser of these signs, but when they have significant comorbidities, for example, patients post-lung transplant or patients with severe COPD on home oxygen, and now they're on 10 liters of oxygen, something like that, you can take smaller clots to try to relieve their obstruction and help them. Very important is duration of symptoms. If you take patients that have told you, I've had symptoms for maybe a month, 6 weeks, these patients, you're not going to achieve much by taking them. They have to be within 2 weeks. There has to be a clear either deterioration or sudden onset of symptoms within the last 2 weeks for the clots to be fresh enough for us to be successful percutaneously. Let me say a few words about high-risk PE before I conclude. This is a case, like I told you earlier today, that high-risk PE, meaning patients come in with hypotension or post-arrest, we're treating them these days in our center as STEMI patients. We want to take them straight to the cath lab unless they're super, super sick, like they're undergoing CPR. These don't do well going to the cath lab. This is a patient that maybe this is like a couple months ago. Patient came to the ER. They thought it was a STEMI, was a little hypotensive, inferior ST elevations, and they called code STEMI on him. Came down to the ER, but clearly something else was going on. On echo, he had this clot in transit, was in his right ventricle, and we didn't even do a CT scan of the chest. Took him straight to the cath lab. Very brief CPR and some epi on the way up to the lab. These procedures are now fast. We came in, took the clot out of the heart in 10 minutes, and then in 20 minutes, all this clot was taken out of his lungs, and he came out of the lab smiling and feeling much more comfortable. So these are very rewarding cases. And I'm going to go over some of the data when it comes to high risk or massive PE. We know from the PERT registry that these patients are still not treated aggressively enough. So only 30% of these patients are treated with some advanced therapy, 40% in advanced centers, and the mortality is still high. So catastrophic PE is 40%, high risk PE is 17%. And when we talk about interventional treatment for these patients, we talk maybe catheter-lytics or mechanical thrombectomy. But in my mind, it's not really catheter-lytics. It's doing something mechanical. So either ECMO or mechanical thrombectomy. I think surgical embolectomy is behind us. I mean, most of the time, we can solve the issue with one or combination of mechanical thrombectomy or ECMO. And the trial that I wanted to share with you before the conclusion is the FLAME trial, which is a trial done on float reaver thrombectomy in patients in high-risk PE. We have seen from our experience before, and we have published some of that data, that if you take patients with high-risk PE to the cath lab, they tend to do well if you do thrombectomy. And so this was a prospective study. It's not a randomized trial, so just be careful. The data you see here is not randomized. It's a just prospective single-arm float reaver trial of patients that were really sick. 64% hypotension, 60% need of vasopressor support, and 20% were post-cardiac arrest. We took them and do float reaver thrombectomy on him with only one patient dying. So if you look at this patient population, you expect much higher mortality. So if you look at the context on patients that we followed prospectively with massive PE, they had 30% mortality. And historically, this patient population was about 28% mortality. So really very promising outcome when it comes to these patients, such that now we just started the PERSEVERE randomized trial, which is the really first real randomized trial in patients in high-risk PE, being randomized 1-to-1 ratio, 200 of them to mechanical thrombectomy versus standard of care. So stay tuned for this trial. I don't expect results because the recruitment of this trial is not going to be very fast. It's a tough patient population. So I really don't expect results in the next year. Probably in a couple of years, we'll start seeing something. ECMO use is helpful in this patient population, although the only data really we have on it is this German registry of acute PE taken for ECMO. And you could see that although the use of ECMO has risen, the mortality is still about the same for ECMO. But what we learned is that ECMO plus additional therapies in very risky patients is more helpful than just putting patients on ECMO or doing thrombolytics in this patient population. So this is my own kind of like algorithm with a lot of changes. I mean, take this with a grain of salt of how to treat these patients. So high-risk patients, and I put under this subclinical shock, so the patients that are normotensive but have enough factors that predict that their cardiac index is going to be low. These I want to take and treat with catheter therapy. The high-risk non-catastrophic, meaning they're hypotensive, they're on pressors, maybe very brief CPR, but they're alive. I would tend to take them to the lab if lab is available. If not, then TPA and then reassess them. Maybe take them to the lab after that if they continue to be sick. Catastrophic PE is different. This is the patient that are you doing continuous CPR or pending CPR, no time to take him to the lab. If they're ECMO candidate, I want to put them on ECMO. If they're not, we want to give them TPA. And whatever you end up doing, you probably end up taking them to the cath lab to do something for them. So if you notice with time, the cath lab is everywhere in my mind in this patient population. Obviously, many remaining questions, and we can discuss all that. what subset of patients benefit the best from intervention, effect of intervention on long-term outcome, role of lytics, role of ECMO, how to remove more organized clots. We really don't know. So all these are very fresh clots. So a lot of questions to answer, but this is what's exciting about this field. And this is where the whole interventional community have come together now, doing more of these and performing more trials. So with this, I conclude my talk.
Well, thank you so much, Wissam, for this phenomenal summary of the data on pulmonary embolism, the interventional treatment of pulmonary embolism. I think the boom in the recent data is just a marker of the growing interest of the community for the interventional treatment of PE. I think that in your remaining questions were, I mean, those are the questions I had throughout your talk. Like in your practice, my first question would be for patients without lytics contraindications, when are you going to choose catheter-based lytics versus going straight for thrombectomy?
Yeah, I think, Louis, I'll take your question a little further because a lot of the question that we get asked is that, for example, after peerless, is there a role for catheter-directed lytics in my practice or other practices? And the answer is yes, there is. So, like I mentioned earlier, there are some patients. I just had a patient not too long ago where had tons of clots in the lungs. They were going to go to surgery, but they had obstructed IVC for whatever reason. They had renal cell carcinoma and other things where it was too dangerous to go through the groin. And I've tried before to do thrombectomy from the neck, but it's too awkward, too kind of like clumsy. It's really the only thing you can achieve right now from the neck is doing catheter-lysis. So this is number one. Number two, you are going to find partners in your practice or people out there in the community that don't do a lot of this thrombectomy and they're not comfortable sending a 24 French or a 20 French catheter to the lungs with all the nuances that come with it. So they're more comfortable sending a 5 French catheter. Everybody can do a right heart cath and send any catheter to the lungs. Even non-interventional people have done this procedure, and they can just leave the catheter there and drip lytics. So that would be one thing that can be offered, and access to patients too. There are hospitals out there in the community that may not do that. We may want to offer something for the patients that are on the sickest patients, but they cannot do thrombectomy, so they can catheter-lytics would be an easy thing to just do on these patients and maybe transfer them after that to a bigger center. So this is where I think lytics would work. There's another, in my mind also, if we look at all this, if you go to conferences and you talk to companies, everybody's trying to say my catheter is better, this kind of procedure is better, you should use it. But in my mind, I see this field moving in the future in 5 or 10 years to where it's like any peripheral or coronary interventions, you have multiple devices on the shelf, and you may be able to use a combination of these in any case. Now, the cost is prohibitive to do that because all these are super expensive, each of them. But I see where, for example, and I had a case last week where took a patient with big clots in the lungs. I did FlowTriever thrombectomy, but the clots were so huge that nothing would come out. She was very sick. So what I did is I did put a Bashir catheter. So in my mind, when I do catheter-lytics, I really favor the Bashir catheter because I think it's more effective at clot and faster at clot removal than regular catheter-lysis. So I then put the Bashir catheter and left it there for 3-4 more hours, and the patient felt better afterwards because I couldn't remove clots. So there are cases where you're unable to do everything intended with your thrombectomy and you want to do catheter-lytics on top of it.
Makes sense. Thanks for the comprehensive answer. I think Andreas Scotty has a question.
Hi, good morning. Thanks so much for this talk. It was really comprehensive. I have just a practical question for you. For those cases in which we have a clot in transit through the PFO, how do you usually manage them, and do you have any specific advices for when we do these cases?
Very, very good question. So clot in transit through PFO, I still think if it's a big clot, if the patient is a surgical candidate, I feel like that's the safest thing because it's no matter what you do, it's very hard to predict when this is going to travel to the other side. That being said, a lot of these patients are too sick for surgery, or your surgeons may not be comfortable or familiar taking these patients to the lab because the majority of these already have a big clot in the lungs. So when you take them to remove that clot, if you open the chest and they still have an RV dysfunction from a PE, they're not going to do well. So you have to also go after the clot in the lungs to improve the RV function post-op. If they're not surgical candidate, what we've done is we've gone with thrombectomy for these. You could do angiovac if you want. I've kind of like favored myself doing flow-retriever thrombectomy. It's easier to just do manual aspiration on these. But if there is a clot traveling in transit, I put a sentinel device in these patients. And I've had mixed results. I'm talking, I haven't done 20 or 30 of these. I've done about 6 or 7 of these. And I've had a couple cases where the clot remained, one clot on the left side remained, and a patient where the tiny bit of that clot disappeared. Luckily, the patient did not have a stroke. I don't know where it went in the body, it was not in the sentinel device. But in the majority of the time, you can remove the whole clot and it passes through the PFO in your catheter. There has also been more experience lately, and I've done a few of these where you cross the septum to do thrombectomy on clots on the left side in non-surgical patients. So I've had clots that are sitting, for example, on a mechanical valve, on the left-sided mechanical valve, or a big clot in the left atrium that you want to remove. I've done after these with catheters, 16 French catheter with a transseptal. So we've started to kind of do more and more of these left-sided disease, but they're very tricky and there's still a significantly higher risk for stroke.
Thank you. Maybe I'll give
maybe
Asma Khalik.
Hi, Dr. Jaber. This is Asma Khalik. I'm one of the interventionalists, and I also am the director of RPE program. And we have been lucky that we have been able to serve a lot of patients in the last 2 years. And it's great to hear this talk, validating many of our own thought process. And I was also able to see you give you a late breaking trial on peerless one. It was phenomenal. Thank you for being a leader in the field. I do have a question specifically regarding that. So while people who have done this for a few years, we are such firm believers in the technology, is that what I'm finding myself and others is we're in a little bit of a scientific impasse. I feel like now that we are also a Center for Peerless 2, I am feeling that we have some reluctance or hesitancy to enrolling patients because we know that this technology works. So how do you get over that mental block?
Such a good question, Asma, and good to see you here on the talk. A great question. A very important point is two points here, Asma. So there are people that actually don't believe in intervention. So you're gonna have centers. So in your center, maybe you're a strong believer, but there are other centers and other practices and ICU docs and pulmonologists that don't believe in this intervention at all, except in high risk with TPA contraindication. So there's definitely need for science to change the guidelines to prove that what we're doing affects outcome. And the only way I think to get over, but in practices that believe in this strongly, because we see it, I think it's good to remind ourselves that regarded with everything I've shown, there hasn't been anything to show us head to head that we affect mortality in these patients. So if you look at data in aggregate, you see that patients in general do well in 30 days and 90 days. So here the question is for the patient, and this is how when I'm recruiting patients for the trial, this is what I talk to them about. I'm not treating you. I'm treating the patients. So I'm taking the patient, I'm randomizing them to intervention versus no intervention. But if they deteriorate, or if something happens to them, or if we're not happy with their progress, I'm still going to intervene on them. And this way, I think it's easier to convince the patient to get in the trial, because many of these, over a few days of anticoagulation, they're going to get better and they're not going to intervene on them. And then we're going to end up having better data. In fact, we try as much as possible. Every patient I see in our practice and we get consulted on, we try to put them in a trial. And that's what I urge everybody in the community, because as you use the right term, scientific impasse, unless we get more data and more solid data, we're not going to change the guidelines, and we're not gonna make this a more universal treatment for everybody everywhere.
Absolutely, great point. I will make sure to remind myself and all our colleagues that that is absolutely a valid point. And I feel like that is the only way we can actually show significant, divergence in the curves where we know that, thrombectomy of whatever sort is going to be probably superior to, other therapies. No, thank you. Very, very good point. Thank you.
Yeah, thank you. Do you mind if I want to address something in the chat? Because somebody asked just before the time is over. There's a question that's an important question that gets asked about optimal timing of catheter treatment for subclinical shock. Do you take these emergent to the lab? This is asked or take them overnight. This is asked frequently by interventionalists because the question is, oh, we're going to start this program. Do we come in at 2 a.m. and do these cases every time? It's a huge burden. We used to do that early on, but we found that the majority of these patients can wait for you for the morning to do something. Obviously, you prioritize based on how sick they are. So if the patient has a blood pressure of 100, they're tacking at 130 and they're on 100% face mask, I want to take these patients right away. But if they're able to speak and the heart rate is maybe 100 to 110 and you're giving them IV fluids, these are patients that can wait till the morning. Most of these do well. So with time, if you think about how many times we come in necessarily at night to do something about these patients, I would say less than twice a year that we have to come in the middle of the night to do something about these.
Thank you, Wissam. In terms of support with you mentioned the role of ECMO. What is the timing of ECMO in your practice, and is there a role for isolated right-sided support like RP Flex or Protect Duo? Do you put patients on ECMO before the procedure, or you do the procedure and you see if they get better and then put them on ECMO? And do you use at all RP Flex or Protect Duo?
Yeah, very good question. One of the reasons I take the patient, like I said, like a STEMI to the cath lab is to avoid ECMO. I mean, we know that ECMO stabilizes patients right away. I mean, ECMO is a wonderful thing immediately, but we all have seen tons of complications, right? I mean, these patients next day, now you're going to have all the complications, and half of them don't do very well on ECMO. So the idea is to avoid ECMO in these patients. So in my mind, if somebody is getting ongoing CPR, or if you're increasing the second pressure and this pressure is still 70, this is the patient that I want to put on ECMO before I have him arrest in the elevator. These are bedside ECMO. If the patient is one pressure, blood pressure 100, or if they've done very brief CPR, but now you kind of have some pressure, these patients I want to take to the lab. I want to try to do thrombectomy before I put them on ECMO. But in all these patients, I start with 2 venous lines, and I start with an arterial line also in the groin, because I'm ready to put them on ECMO in the cath lab in case they arrest. And I ask for the ECMO techs and for the ECMO machine to come in and be outside the cath lab to be ready in case something happens. So and in the majority of the times you can find that these patients, you just come in, take the clots out, and get out. And I want to do these very fast. I don't sedate these patients, number one. Number two, as I'm crossing the right ventricle, I frequently give them norepi or something like that, bolus, so that to shore the blood pressure, because the blood pressure might drop as you put a catheter inside the pulmonary artery. But you find that as soon as you get there and suck the clots, they immediately get better. So this is what you want to achieve. It's really an immediate improvement. It's that fast. If they don't do well, I've had patients where, as we're crossing the heart, they were really super sick. I couldn't do anything. We put them on ECMO at that time. But we were ready to do that with the catheters in place.
It's striking me every time the way they improved right away with the relief of the obstruction, and also how quietly sick they are before going to the cath lab with those low index and low PSATs, and you see an immediate improvement. A question from Andrew Mignati, the director of the cath lab here at the Moses. Could you comment on the cause of death at 30 days? I guess in the peerless trial, maybe.
Yeah, I see that. The patients that, so there's one patient actually that died from the one patient in the CDL that died is so there's two things. So there's a patient that died from this in the CDL. He died from the PE itself, but died 7 days afterwards. So had like complications, deterioration in the cath lab, and then was intubated, stay on, and then died after 7 days. So this is kind of like, this is one of the cases. There's another patient in the thrombectomy arm also that had deterioration, was bailed out, and also died after 7 days. So you can count both these as really PE-related death. And I think there's one case that died like 30 days, died not related to PE itself. This is as far as I remember. That's my recollection.
Thank you for the precision. We have a question from our cardiology fellows. Now that the cardiologists are increasingly taking care of these patients, we encounter them more often in the clinic, a lot of heterogeneity in the management and long-term follow-up and regarding anticoagulation. They're curious about how these patients are followed after the index event at Emory, and do you incorporate pulmonology and hematology in their follow-ups after the index presentation?
Good question. I mean, this all depends on local cultures and who's interested in what. So, for example, we have hematologists here who are very interested and specialize in thrombosis. You may have also that in your center. And they follow up on the majority of these patients, mostly when it comes to length of anticoagulation and other workup that could be done as an outpatient. We had a pulmonologist who also had interest in seeing this patient. We have a pulmonary hypertension clinic also with interest in PE. So it's not really one clinic with a PE banner on it. It's kind of fitting these patients with people that have interest in PE in general and understanding of post-PE follow-up, screening for CTEPH, screening for symptoms down the road. The CTEPH clinic sees a lot of these patients, especially when they had significant RV dysfunction or pulmonary hypertension. In general, all the patients that we end up doing intervention on come back to the interventionist to see in the clinic within kind of a month afterwards, and then we release them to be seen by the pulmonary hypertension clinic or one of the people that I mentioned, based on what really needs to be asked. If they're really low risk, nothing to do, I would just send them to the hematology clinic. The patients that we didn't intervene on from the beginning get sent to one of these. But like many centers, we don't have a quote unquote PE clinic. We just have people that are interested in doing PE.
Thank you. We have a question from Joanna Katza as well regarding the timing of the time window that you would take those patients to the cath lab, and also do you have to come back sometimes after the initial presentation for worsening symptoms? And I guess because it's a second question on timing of the procedure regarding to present related to the presentation. There's in those talks we often hear about a parallel between the evolution of evolution in the treatment of myocardial infarction and evolution in the treatment of pulmonary embolism. Do you foresee in the future a door to catheter kind of thing?
Yeah, good question. Probably yes for the high-risk patients because they will die on you at any time. So the earlier you work on them, the better it is. The other more stable patients, at least in our practice, I'm sorry, it is within 24 hours. So let's say if they come in the evening or at night, they get done kind of in the morning hours next day. If they come in that morning, we do them kind of like either immediately in the lab if there's availability or early afternoon. And you kind of prioritize on how sick they are because, I mean, obviously cath labs are busy and you want to delay some cases. And if you're not the one in the lab, you want to convince your partner that can at least take your spot to do that. I mean, it works well with us because most of us, we have buy-in from all our group in terms of PE treatment. That's a big issue when you have a practice where there's not a lot of buy-in and you're one or two people that trying to push others from doing the routine business in the cath lab to try to do these urgent cases, and your case end up being done at 8 p.m. at night. So all these are kind of like things to think about in the practice, and it's kind of more education. So it ends up doing them within kind of like the same day. We've had patients though where we wanted to go elective, and I do that a lot. Patients 70-year-old who doesn't look that bad, maybe troponin a little elevated, RV moderately enlarged, I don't take these patients to the lab necessarily. I put them on anticoagulation and I come see them later in the afternoon or next day. They walk around, and if they still desatting a lot, if they feel, listen, I'm not feeling better, I don't feel good, we take them to the lab. So I would say up to 2 to 3 days I've waited for them patients before taking them to the lab. But if you decided that you want to intervene on somebody, the earlier you take them, the better it is, because this clot is getting more and more organized.
Thank you. And very practical question here from our fellows for high-risk PE who receive TPA. How long do you wait before going for a catheter-directed intervention if needed?
So if TPA is given and they keep deteriorating, we take them anyway, right? But if they're relatively stable, they're on 1 or 2 pressors and we're waiting. So I want to wait until the TPA is over. So usually the TPA is over 2 hours. And when the TPA is over, we kind of reassess. Almost all of these are going to be a little better at that time. I haven't seen somebody, the people that don't do well with thrombolytics are the people that have ongoing CPR or recurrent CPR. They don't do well. They go on DIC, they continue to worsen. This is why, in my mind, ECMO is the only solution for these patients. But the patients that are a little more stable, you give them TPA, they typically get better in a couple hours. And so you kind of like, based on how they're doing. So if they're still on pressors, if they're still requiring a lot of oxygen a couple hours later, I would take them to the lab. And it depends on how sick they are, obviously. If they're getting slowly better, I'm just going to wait on them. I don't want to stick them when they just got systemic TPA. So some of them, we've taken them next day if they still require a lot of oxygen. But by that time, I almost always repeat the CT scan because they could be sick from, for example, bleeding or little kind of DIC. Some of them end up in from the shock that they were in. Or so you take them, you do repeat the CT scan. If they're super sick, you don't. You just take them and do pulmonary angiograms faster. But if they're stable enough to get a CTA, I would take them down for a CTA because you discover frequently that now the clots are mostly distal and you're not going to do much in the cath lab.
Makes a lot of sense. I think, no, that's the same question. I think that's all for our questions. Thank you very much for your talk, Wissam. That was really phenomenal. I think the community, the interventional cardiology community, but also the general cardiology community is very excited about the advances in the treatment of PE, probably because now we have interventional treatment for it, and the outcomes are so good.
Perfect.
So we're looking forward to Peerless 2 and more data on this. And thanks again for your talk.
Thank you. Thank you very much for the invitation. Good to be here.
Yeah,
Thank you very much, Wissam. Nice to see you here. Bye-bye.
Nice seeing you too, Asma. Take care.